I'm going to tell you a little bit years of our program and also some clinical characteristics and key findings we found within those 2 years. So, established in 2022, Rap Without Walls was started by Dr. Amy Ewell and Dr. Hannah Brown through funding with the Jack Sauter Foundation, with the realization that not every patient can come into office-based care. It doesn't work for every patient. So Boston Medical Center developed this program, which provides coordinated specialty care for youth with psychosis and substance use within the Boston community. So this is a community-based program, which includes meeting patients at libraries, schools, homes, even the Dunkin' Donuts across the street. And services are inclusive of individual therapy, family psychoeducation, medication management, peer support, advocacy, and patient navigation. And here's a picture of the current team. So in the first 2 years, 38 patients have been engaged within our program. And engagement in our program is defined as youth who are a part of the program and have met with the clinician for at least 3 times for a substantial amount of time. So that's about 3 30-minute appointments with a clinician. Our patients overall, as you can see, the average age is around 21 years old. And most of our patients are Black or African American, male, and identify as non-Hispanic. So to go a little bit into the clinical characteristics and key findings, we collect data from the MapNet battery and when patients join our program and are considered engaged. So that's our baseline data. And of all 38 patients, we see that schizophrenia is the most common type of psychotic disorder at around 31%, followed by schizoaffective disorder, and then the other category as well, which overwhelmingly we see is unspecified psychosis. And then kind of going to a little bit of the clinical characteristics, when we're looking at the number of youths engaged with lifetime use of substance, we have a more detailed account when looking at the Who Assist form within MapNet data. So at baseline, when we collected this data, we see that of the 38 patients, 20 just responded to this questionnaire. And we see that most patients use cannabis, 18 out of 20 to be exact. And then that's followed by tobacco use and alcohol use. And then when asked in the last 30 days, we had 18 out of 30 patients respond. And we see that, again, cannabis is most commonly used, followed by tobacco use and alcohol use. Now, to talk a little bit about our key findings, within the first 2 years, Rap Without Walls had 1,145 completed appointments between the 38 engaged patients, and 823 of those were completed within the community. The graph behind me shows that the monthly breakdown of the visits per patient within like a month. And as you can see, overwhelmingly, the light blue represents the community visits. And we've had feedback from our patients who have told us that community meeting is more preferred than office visits and community health visits, or telehealth visits. And we want to take time to thank Anne Berrigan, who is our program manager and therapist within Rap Without Walls, and Christian Wolf, our therapist, for, for collecting this data. Are there any questions?
Any questions?
Yes, Margaret.
How many encounters you have with people?
I'm sorry, could you say that?
How many encounters do you have with people?
So those are just the completed and like engagement, like the completed appointments. Those aren't all of the encounters that we've had. Yeah. The 1,000. The 1,000 isn't the completed appointments. That's the completed appointments, not the overall like encounters that we've had with patients. Yes.
Thank you. Have you been able to parse out organic psychosis versus what is substance involved psychosis with your patients? There's quite a lot of substitute there, I think.
Dr. Brown will answer that question.
It's really difficult, I think, what substance use and others. So we accept anyone who carries a diagnosis of substance use psychosis or primary psychotic disorder with comorbid substance use, but it's really difficult with the only service. Like if you ask me for answers, I think more people do it.
Yes.
One of your slides shows a change in the kind of substances, kind of drugs that were used before the program and then during the program. How did those change and why?
I think that the cannabis is pretty consistent. You're doing specifically the alcohol and the tobacco.
I was just curious about how they changed.
At the time, that when someone comes in, have you ever, and then in the last 30 days? I mean, you can think that some decrease in substance use, and I think I would be back of the engagement with folks. Really focused on harm reduction and decrease in substance use as their particular program.
Yep.
Say just a little about what would sort of wrap somebody to the Rock Without Walls program as opposed to the regular backpack program.
So within the requirements, they would have to have some type of substance use, and typically we serve youth. Yeah, that experience psychosis. That's kind of what the population is, or the basic baseline requirements, I would say. Yeah, and having difficulty engaging in office care. Yeah. Yes.
Parts of the rat protocol. Yeah.
Yeah, we moved away. I moved away from really trying to get people into that. Where so thank you for that.
Okay, thank you, Takaya. I wish we had more time to discuss all these wonderful programs. Our next speaker is Faith Scanlon from Mass General. And she's going to talk about criminal legal involvement among people with first episode psychosis. Very important. Okay.
I'm Faith Scanlon, and I'm excited to share some results today on criminal legal involvement from the RAISE study. People with serious mental illness have high rates of criminal legal involvement. When I'm talking about serious mental illness, I'm specifically referring to major depressive disorder, bipolar disorders, and psychotic disorders. So compared to about 4.5% of adults in the general US adult population who are involved in the legal system, about 14% of people in US prisons have serious mental illness. And unfortunately, criminal legal involvement is associated with difficulties securing stable employment and housing, and disengaging from treatment services. There's one study of 74 patients who were hospitalized in 2 US acute psychiatric units, and they looked at the most common services that these patients accessed during their first episode. So 32% of this sample first came in contact with a psychiatric hospital or emergency room. 26% of the sample had their first contact with a mental health provider in outpatient settings. So that could be a psychiatrist, a therapist, or an outpatient clinic. 20% had their first contact with police, and 14% with emergency medical services or mobile crisis unit, 8% with a family physician. But the important thing here is that, at least in this study, legal contact was the third most common way for people experiencing first episode psychosis to first contact services. And there is evidence that legal pathways are more common for Black people in their first episode of psychosis, which is likely due to structural and systemic racism impacting who comes into contact with the legal system. As Dr. Bob Heinzen pointed out at this conference last year, we know very little about legal involvement among people experiencing their first episode. And there hasn't been a lot of research on predictors of legal involvement among people with first episode psychosis specifically. And if we aren't attending to what might lead to legal involvement, we're likely missing an opportunity to provide extra support and services to help people get the support that they need. There have been years and years of work on understanding the predictors of legal involvement, kind of for people generally, and specifically for people with serious mental illness. But again, and those programs actually have been shown to be pretty effective in reducing legal involvement, which is wonderful. But we also need to understand if there are specific factors impacting people during the first episode period, so that we can expand or adapt our programs to make sure we're meeting those needs. So using data from a large treatment study for people experiencing first episode psychosis, we had 2 research questions. The first one was, what are the rates and correlates of criminal legal involvement, arrest, incarceration, probation, or parole at entry into this treatment study? And then the second question was, what are the rates and predictors of legal involvement in the 2 years after entering treatment during that follow-up time during the study? And we conducted a secondary data analysis on the recovery after an initial schizophrenia episode early treatment program, the RAISE ETP study data. This was a 2-year-long cluster randomized control trial that was conducted at 34 sites across the US. These are community sites. And people were either randomized sites were either randomized to give usual care or coordinated specialty care. For these analyses, we included the 381 adults in the sample who were older than 18 or older. As far as what we looked at data-wise, at baseline, data were collected on participant demographics, diagnoses, frequency of substance use, duration of untreated psychosis, which was measured as the period of time between onset of symptoms and enrollment in this study. Symptomology was also a variable of interest, and quality of life. So for that first research question on the rates and correlates of criminal legal involvement at entry into treatment, 11% of the sample, or 41 people, reported being involved in the legal system in the last month, immediately before the baseline assessments. And we found some significant predictors of reporting recent legal involvement at baseline, which included having less than a high school level of education, having an alcohol use disorder diagnosis, having any other drug use disorder diagnosis, which essentially is a substance use disorder diagnosis that excludes alcohol or cannabis use disorder diagnoses. And then on the positive and negative syndrome scale, the excited factor, which measures hyperactivity, hostility, uncooperativeness, and low impulse control. Higher scores on that were significantly associated with legal involvement at baseline, as well as having a longer duration of untreated psychosis. We split this at the median to kind of distinguish between longer and shorter DUP. And just to kind of illustrate that point here, among people with shorter DUP, 6% reported legal involvement at baseline, compared to people with longer DUP, 16% of whom reported legal involvement at baseline. Moving on to the second research question. What were the rates and predictors of criminal legal involvement in the 2 years after entering treatment? So about 14% of the sample reported legal involvement at follow-up during that 2-year period, most of whom didn't have legal involvement at baseline, actually. So for the people we have both baseline and follow-up data for, 3% had legal involvement at both time points, and 10% only had legal involvement at follow-up. And we tested predictors of legal involvement in that 2-year follow-up period. And we found that having a schizophrenia disorder diagnosis compared to any other psychotic disorder diagnosis was associated with legal involvement during the 2-year follow-up period, as was that any other drug use disorder diagnosis. Longer days of alcohol use and cannabis use were significantly predictive as well. On the positive and negative syndrome scale, a positive factor that measures positive symptoms of psychosis, having a higher score on that scale was significantly predictive of legal involvement at follow-up, as was that excited factor again. Just to kind of highlight here, these are the 2 variables, having any substance use disorder other than alcohol or cannabis use disorders, and this excited factor. These are the 2 that stayed significant both at baseline and again at follow-up. I didn't mention this, I'm sorry. Baseline criminal legal involvement was also associated with legal involvement at follow-up. And so we adjusted for that in the analyses for any of you that's a burning question for. So to summarize, 1 in 5 adults in this sample were involved in the legal system, and the association between duration of untreated psychosis and recent criminal legal involvement at baseline suggests that more rapid detection, assessment and intervention of first episode psychosis could lead to reduced legal involvement for this population. And these findings also highlight the importance of addressing clinical factors in predicting legal involvement, especially substance use. Seems like it's a particularly important one. So having specific conversations with clients about risk factors for legal involvement and working with clients to help reduce those risk factors can potentially reduce legal involvement during first episode psychosis. I would love to talk more after. I know I didn't save time for questions, but you can also email me. Thank you.
Okay, thank you. Okay, in the interest of time, I think we'll go on. Joey Rodriguez is next from Beth Israel, and he is examining language capacity in clinical high risk for psychosis individuals, something that is an underrepresented topic, but we should discuss. Joey, do you want to? We have to change.
Here we go. Thank you. Sorry. Okay. Hey, everyone. Thank you so much for having me. Today, I'd like to talk a little bit about a wonderful opportunity I've had the chance to organize, salute some of our initial findings, as well as future plans. Before I do so, I'd like to thank my awesome colleagues, Melanie and Olivia, as well as Dr. Friedman Yakubian and Dr. Ruiz Yu for the incredible support. To begin, I'd like to talk a little bit about the Massachusetts Psychosis Prevention Program, which focuses on improving the mental health and wellness of youth and young adults in Massachusetts who are at clinical high risk for psychosis. M3P's mission is centered around early identification, prevention, and intervention activities. Importantly, M3P aims to ensure behavioral health equity, accessibility, and timely care for young people at CHRP, regardless of race, ethnicity, gender, socioeconomic status, sexual orientation, geographic location, and language. Salud is an effort to support the facilitation of these goals, specifically language. Salud stands for the Spanish Advisory Board for Linguistic Development. It comprises of a multidisciplinary team of Spanish-speaking staff that you could read here from Latin backgrounds, all of whom provide care in Spanish for youth experiencing psychosis. Our long-term aims are to connect Spanish-speaking providers together in order to ultimately identify and address specific needs in this field, eventually to develop priority areas and establish best practices. Before I talk about the QI project that I did and we did, I'd like to briefly talk and provide a little bit of context on Spanish-speaking residents in Massachusetts. Big picture, according to the most recent Census Bureau 5-year estimate, Spanish is the most common non-English language spoken in households in Massachusetts. I'd also like to say that their big picture is a large unmet need for Latin youth. In the most recent Massachusetts Health Insurance Survey, Hispanic residents were nearly twice as likely to report unmet behavioral health needs compared to other populations. I bring up this data because it speaks to the value of M3P's goals and Salud's, which is including and improving youth functioning by expanding access to evidence-based services and growing a statewide workforce capable of developing these services. So that concludes my contextualization. Now I'm going to move on to what we did. To begin, to examine language capacities, we employed a mixed methods approach. We included both semi-structured interviews facilitated within focus groups of Spanish-speaking providers, as well as a dissemination of 2 types of surveys. Starting with the surveys, we collaborated with early psychosis experts and designed the surveys based on Samatsi's and Talley's comprehensive review of how to evaluate mental health services. The framework they developed breaks down service evaluations into 8 dimensions, but these 8 dimensions are umbrellaed under 3 key areas: access, safety, and service continuity. We use this framework in collaboration with EP experts to create a clinician survey, which we distributed to key team leads in clinical high risk for psychosis outpatient programs to gain a broader understanding of clinic-wide language capacity. And then we also distributed this to Spanish-speaking providers who work with youth experiencing psychosis. When we disseminated the surveys, we received all of them back completed. We hope to compare the similarities and differences. Alongside the surveys, we conducted semi-structured focus groups with the multidisciplinary team of providers. We did outreach within the regional network of early psychosis, as well as create a semi-structured interview with EP experts. We overall had 10 Spanish-speaking providers in our focus groups. The focus groups were framed with an introduction hour, followed by 4 bi-weekly focus group hours, along with a recap hour, and they were recorded and transcribed to review. The focus groups also prompted us to revisit our transcriptions for deeper analysis, leading to an ongoing thematic analysis. So what did we find? So these are just initial findings right now. I'd like to start by introducing this graph, which compares the direct access to English services that CHRP services can provide with direct access to Spanish services in these same CHRP services. Now, it's important to note that according to the report, every clinic has access to interpreter services, meaning they can provide services in languages other than English through interpreters. Except for neuropsychological assessments, every service or appointment can utilize their interpreter services. I just wanted to mention this. because it's great that all of these CHRP services offer access to interpreter services. It's definitely a step forward in improving access to care. I'd like to just highlight direct access, meaning services provided by fluent clinicians in Spanish without needing interpreter services. So we're comparing equitable direct access to services in English. To begin, in diagnostic evaluation, care coordination, individual therapy, and family therapy, we see programs are approaching direct access for Spanish-speaking clients. This is a positive trend towards equitable service availability. There are continued steps being made in psychiatry, school and work coaching, neuropsychological assessment, and group therapy to make these accessible, directly accessible in Spanish. Next, we asked, from these services we just described, what would you like to see improved or expanded to be available to clients in Spanish? I just wanted to highlight that across the board, as you can see, all clinicians who completed the clinician survey and all clinic directors agreed that every service could benefit from being improved and expanded to better offer direct access in Spanish. Finally, I'd like to touch base about us mapping the priority improvement areas. So what can specifically be done and what priority areas need to be focused on to improve these gaps and these opportunities for improvement. So when it comes to the findings on the left, we see that more staff, so more Spanish speaking staff who are able to provide these services are agreed by both clinicians and clinic directors as a need, followed by diagnostic materials, including translations of public psychoeducation resources and, translations of assessments. This was followed by proper and just more training opportunities, as well as from the clinicians, community outreach, and from the clinic leads, funding, along with other reasons. I'd also want to touch base, and I know I'm really short on time, just a few highlights, and that aligned with a lot of the focus group conversations we had over the 3-month period. Clinicians stressed having more opportunities to train Spanish speakers, having more opportunities to disseminate and share resources, more funding and an orientation to services for Spanish-speaking families that better facilitate pathways to care, as well as having more bilingual staff and cultural competency training for all staff. To conclude, I'd just like to say that all CHRP clinics reported the need for expanded clinical services. There is, preliminary alignment on the need for what needs for the future steps and priority areas that should be looked into more. And there is also alignment on which services should be made priority to be improved in these outpatient programs. I'd just like to have special thanks to the 3P program, Psychosis Research Program, Response to Risk Research Program, SAR Reset CEDAR, these outpatient CHRP programs, along with every Salute advisory member that was able to have a conversation with us, and MapNet, and To Be Epic. Thank you.
Questions? Yeah, there's a question right there, Joe.
Yeah, that's a fantastic question. So in my poster, unfortunately, I didn't have enough time in this presentation. I said the best next step for Salud would be collaborating stakeholders between clinicians and the Spanish-speaking people who have received the services. I think that would be an incredible step to really consolidate, gain multiple stakeholder input to share these decisions in a way that's meaningful for sustainable care.
Yeah, thank you, Joe. Thanks. That was really important. I'd like to see that in Portuguese and also Asian Creole. So those would be the next steps. Okay, Our next speaker is Alma Bartnik from ServiceNet Prep Program. And Alma is talking about understanding and innovating milieu treatment in an early psychosis program in rural Massachusetts.
Thank you all for being here today. I feel really honored to be here. My name is Alma Bartnik. My pronouns are they, them. I work with ServiceNet's Mental Health Recovery Division. And today I'll be speaking with you about understanding and innovating milieu treatment in an early psychosis program in rural Massachusetts, though my slide says Western Massachusetts. So a really quick overview, I'll be speaking with you about the Prep West program, our community engaged participatory research study, our preliminary findings, and then I'll end with a brief discussion and next steps for the study. So Prevention and Recovery in Early Psychosis West, or Prep West, is a person-centered, milieu-based, coordinated specialty care program located in Holyoke, Massachusetts, for individuals living with early psychosis. Centered around each person and their goals, the program provides support through counseling and coaching, individual and family psychoeducation, supported employment and education, peer support, outreach and engagement, medical intervention, including low-dose prescribing and wellness activities, and of course, the milieu, which is our focus for today. So the milieu as the clinical service core helps address negative symptoms of psychosis and helps individuals to stabilize their lives, to recover, and to resume developmentally appropriate social and occupational functioning in their communities. I'll note that though this is a milieu-based program, individuals enrolled at Prep West may or may not participate in the milieu, and that can vary over the course of each person's treatment plan and as they progress through their treatment goals. So our present study utilized a community-engaged participatory research approach with two aims, the primary aim being the use of focus groups so that Prep West clients can actively contribute to and co-construct the primary means of data collection, the interpretation of results, and the development of intervention strategies. The secondary aim was to better understand how Prep clients experience the milieu and what actionable steps can be taken to develop those intervention strategies that will improve the milieu for the community that it serves. So eligible participants were those currently enrolled at Prep West between the ages of 18 and 30 and with a diagnosis of a psychosis spectrum disorder condition. Our exclusion criteria were those who were not participating in the milieu, those who had been enrolled at Prep for fewer than 3 months, and those for whom participation was not clinically appropriate at that time. We conducted 3 semi-structured focus groups in 2024. Those ranged in size from 2 to 3 participants and lasted between 30 and 60 minutes. All of these focus groups were audio recorded and transcribed later. So we completed line-by-line coding, from which we developed a code book that was then further revised as needed. We completed 2 rounds of coding in vivo with our intercoder reliability assessed at 99%. And then we utilized thematic analysis, drawing on the principles of immersion crystallization methodology to identify our preliminary themes, which I'll share in a moment. To date, we've gathered feedback from 11 participants, which represents about half of those participating in the milieu. The median length of time in the program among those participants was 30 months. And to quickly summarize the demographics shown here, the most common primary diagnosis was schizophrenia. About 2/3 were men, half were white, and a quarter Black or African-American, and about 18% Hispanic or Latino, though I'll note that data were missing for about 1/3 of participants there. And the average age was just under 25. So in our preliminary analysis, we identified 2 core themes. Those were safety, respect, and belonging in the milieu environment, and the social and therapeutic value of peer connection. So I'll begin with the voice of a participant speaking to their experience of the milieu environment. You have freedom to be calm being yourself, and they're not going to force you to do anything. Individuals talked about the importance of having a place in which they are accepted for who they are and therefore able to be themselves. Some also describe this as a place in which no one is judging them, or a quote-unquote judgment-free zone. In addition to these explicit descriptions of being accepted, when describing the milieu, participants use words like warm, calm, welcoming, peaceful, and safe. Some also describe the more home-like atmosphere of the physical environment at the milieu. And finally, participants talked about having agency in their treatment and in their engagement with the milieu. And these discussions around choice were often about being able to opt out of groups and activities as needed and working with staff who really listen to participants and what they want. So one participant put this really succinctly as, they treat us like adults. For the social and therapeutic value of peer connection, I'll again begin with a quote. Now I'm able to socialize with other people, and I feel more connected with other people, and I'm able to speak up about my experiences and relate to other people so they know they're not alone and reminders of I'm not alone. Nearly all participants talked about connection, and particularly the value of connecting with others of similar ages and with similar experiences to their own. They talked about being able to share their stories with and understand each other, being able to encourage, support, and motivate one another, and as this quote highlights so well, remind each other that they're not alone in what they're experiencing. Participants also shared stories of isolation and judgment they've experienced elsewhere. A number of people talked about losing friends after diagnosis, people not being able or willing to understand them, and that inhibiting their ability to socialize. So participants talked about the milieu not only as a place that gives them the opportunity to connect with others, but that the milieu has helped them learn how to socialize, learn how to connect with others, and to become more comfortable in doing so. So just to wrap it up, these themes highlight participants' positive experiences with the milieu and the impact that those have had on their well-being. In the coming months, we will conduct further focus groups to gather additional feedback and experiences, including from some folks that have been more recently enrolled at Prep West. A key part of the participatory approach, and one of our aims, as I mentioned earlier, is to not only learn from participants about their experiences, but also to learn from them the best way to conduct future data collection and learn about what intervention strategies may be developed. So in addition to describing the quality and impact of participants' experiences, our future analysis will also focus on identifying those future methods for data collection with the aim of identifying and implementing actionable intervention strategies to improve the milieu for this community. I apologize that I don't have a thank you and question slide, but thank you. That's where I'll end for today. I'm happy to take questions. Thank you. I don't know if I have time.
Thank you. We have time probably for another question. Yeah. Go ahead. Yeah.
Yeah, that's a good question. And I told my team I wouldn't chuck questions back to them. I'm not sure whether we have data. My impression is that most folks live local to the Holyoke community. I see Cassidy nodding. Yeah. So Holyoke is, I'll speak to this and John, jump in if I'm wrong. Holyoke itself is a city. It's also located in Western Massachusetts in a predominantly rural region. And so I think part of the impact there is the ability to connect to other services or just even simple things like attending the milieu. I know there are some folks who don't participate because they cannot get there. They have no transportation to get there. So that's my brief answer to the impact of the rurality of it. Mm-hmm. Mm-hmm. Yeah, thank you for asking about that. So again, Cassidy, jump in if I get it wrong, but my understanding it's a combination of groups and activities. So that can be like skill building groups or arts and crafts groups. There are peer support services in the milieu. That can also include outings and trips to the local gym. But as I said, participants may or may not complete each of those activities or groups on a day-by-day basis. And there's multiple rooms in the physical space. And so there may be a group going on in one room and folks can go into another space if they need to.
Yeah. Maybe you can answer more questions.
Yes, I'm happy to. If you would like to ask for my email, I'm happy to provide it later and talk with anybody about it. Yep.
Yeah, thank you, Alma. It's good to hear from someone outside of Boston. Okay, So our next speaker is Megan Good from Beth Israel, and she's going to speak on cannabis use and how it affects the social and occupational functioning of first episode psychosis. Megan?
Hello, everyone. My name is Megan Good. I am an early course psychosis fellow at BIDMC. So you can usually find me at the Aspire Clinic. However, I work with several other MapNet clinics, including MGH Reset and the Edinburgh Center. Today, we are going to explore the effect of cannabis use on first episode psychosis patients participating in coordinated specialty care clinics. So we know that there's a link between cannabis use and psychosis. 65% of our MapNet patients endorse lifetime use of cannabis. Cannabis, especially high THC products, pose a psychosis risk. And we know that cannabis can also act as a trigger for first episode psychosis, especially in patients who have an innate vulnerability, such as genetic predisposition or cannabis use from a young age. Approximately 1/3 of patients with PhEP have clinically significant cannabis use, and 93% of all illicit drug use in PhEP patients includes cannabis. Cannabis can also affect functional outcomes for patients with psychotic disorders. This is important because our MapNet patients are quite goal-focused. 71% of patients have goals related to employment, and 70% have goals related to education. But patients who use cannabis have worse outcomes in a variety of domains, and this includes education, symptom burden, employment, global functioning, social functioning, and quality of life. We wanted to further test these assertions. So we asked whether cannabis use affects the social functioning, occupational functioning, and quality of life in individuals with first episode psychosis participating in MapNet coordinated specialty care programs. Let's talk about research methods. Data was collected from the MapNet assessment battery at 3 time points, baseline, 6 months, and 12 months. Patients were then divided into 2 categories, cannabis users and non-users. Users are defined as any participant who reported cannabis use at any time during treatment duration and the 30 days before treatment initiation. Non-users reported no cannabis use at any time in the 30 days leading to treatment initiation or during treatment. Lifetime use before treatment duration was not excluded from the non-user group. We used 3 outcome measures. Social functioning was measured via the Global Functioning Social Scale, or GF Social. Occupational functioning was analyzed via the MyRic Occupational Functioning Scale. And lastly, quality of life score is a subjective 0 to 10 that patients assigned themselves. Then we used 2 different data analysis, a between subjects analysis and a within subjects analysis. The between subjects analysis included an average score for each group, users versus non-users, at each time point, baseline, 6 months and 12 months. A 2-way ANOVA and multivariate linear regression were then performed to identify statistically significant relationships. The within subjects analysis was used to look at changes in outcome measures over time. This analysis only included data with repeated measures. The change in score from 0 months to 6 months, as well as 0 months to 12 months was calculated, and then a mixed model ANOVA and multivariate linear regression were used to perform to find any statistically significant relationships. So what did we find? Okay, here is an overview of our participants. There is a statistically significant difference in sex between the 2 groups. I'd also like to call your attention to lifetime alcohol and tobacco use. As you can see, cannabis users had much higher rates of tobacco and alcohol use in their lifetime. Looking further at results, to orient you on each slide, the top graph represents the between subjects analysis and average of all data at each time point, and the bottom graph represents the within subjects analysis, which again looks at changes over time. So let's look at the effect of cannabis use on social functioning. In this analysis, we found that cannabis users actually had better social functioning than non-users at both 0 and 12 months. However, there was only a statistics, oh my goodness, significant relationship at baseline between the two groups, but not during treatment course. Please note that even though the non-users had lower average social functioning, they showed greater improvement in score from baseline than the cannabis users. The within subjects analysis echoed the findings of the between subjects analysis, but there were no significant relationships to report. Overall, cannabis users did demonstrate higher social functioning, but the relationships were not statistically significant when compared to non-users. Next, we'll look at the occupational functioning. The between subjects analysis demonstrated that cannabis users had worse occupational functioning at each time period. Most importantly, at month 12, non-users had a statistically significant higher level of occupational functioning than users. The within subjects analysis is worth discussing further. As you can see, from 0 to 6 months, both user and non-user scores demonstrated a statistically significant decrease in occupational functioning. However, due to low sample size, significance is likely overestimated, and therefore the analysis of that part is likely not valid. Lastly, let's look at quality of life. Quality of life, in my opinion, is actually the most important outcome measure because patients are assigning the score to themselves. It demonstrates their current subjective state of being and satisfaction with treatment and life in general. So looking at the between subjects analysis, cannabis users had lower quality of life in each time period. This difference was significant in both months 6 and 12. Non-users endorsed a greater quality of life as early as 6 months into treatment. The within subjects analysis reflects these findings, showing a greater increased quality of life in non-users, with the change in quality of life score from 0 to 12 months being statistically significant. Limitations of this analysis included the fact that this is real-world naturalistic data. Because of this, there's heterogeneity of treatments in patient populations and also variability in inter-rater reliability. Ultimately, this analysis does suggest that cannabis use negatively impacts both occupational functioning and quality of life in FET patients throughout their participation in CSC programs. Clinically, this means that abstinence from cannabis should be encouraged and harm reduction practiced to avoid exacerbating symptoms and producing further behavioral deficits. Thank you for your time. Here are my acknowledgements and my sources, and I'm happy to take any questions with this.
Thanks, Megan. Yeah, please. Yeah, maybe let's take one question right here.
Yeah, this is really interesting. I guess the question I have is, I'd be really interested to know if you divided up the sort of clients into non-users, very occasional users, and used a lot.
Yeah.
You might see a very different.
Yeah, I tried to divide it further into other groups, but it's difficult because the data number is limited. I also tried to do an analysis with patients who started use during treatment and also patients who ceased use during treatment. So I definitely think further analysis is warranted to see those specific patterns of use and how much they affect symptom burden and other outcomes.
Yeah. Yes.
So I guess my question would be like other ways in which you talk about it.
Sure. So in my multivariate linear regression, I did include different factors to assess for their significance in the analysis. I'm trying to remember specifics for each one because there were specific ones for each analysis. I don't believe race was a factor if I'm remembering correctly, but I can double check that and get back to you. I'm happy to share my data.
It's more research.
It needs more research at this point. frankly.
Yeah.
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 I'm
Thank you.
happy to share my data with you.
Thank you very much. Yeah, I think there's much more research we need to do about cannabis in our communities, and hopefully we can all get together and find some interventions that will help. Okay, our last, but not least speaker is Paul Hyry-Dermith, from the Brookline Center, for Community Mental Health, and he's gonna talk about the school mental health system and development and awareness of early psychosis.
Hi, everyone. I am not going to share a research study with you. We do research about Bright, but that's not what the focus for me today is. I just want to talk to you about schools, because I feel like there is so much happening in the school mental health space in Massachusetts. It's a really dynamic space. I also want to say that I worry a lot about disconnection between schools, universities, and workplaces, and then community treatment and institutions working around these issues. So I think I just want to share some things about schools so you can be thinking about some of these connections. So I'm part of the Bright program. We are a program with the Brookline Center. So great to see many of my colleagues here today. The Brookline Center is doing great work in so many spaces. We are a very specific school-based program and intervention that we support. I'm going to talk for a second about comprehensive school mental health systems, a second about Bright, and a little bit about how I think we can create stronger connections together. So MTSS stands for Multi-Tiered Systems of Support. It's the way we in schools take the public health, primary prevention, early intervention, intensive intervention framework and bring it into schools. It is the most common way. If you go to schools and you hear them talk about their systems, you're going to see this triangle all over the place. You're going to hear people talking about this. Number one, the tiered interventions are really important. I'm going to talk about that, but this is also a systemic way of thinking that includes what we think of as infrastructure, the critical nature of data, in addition to tiered supports and services. So when we're looking at what's happening in schools, we're thinking about people, teams, and data systems. And the quality of a school mental health system is going to very often be determined by who the people we have are, how good they are, right? How well developed the teaming structures are in the chaotic environment of the school, because it's a chaotic environment, right? And then how well school teams can use data to make decisions, to progress monitor, to assess outcomes. Then when we talk about tiered supports and services, I'll get into what I mean in a second, but first of all, just how we think about the tiers. So it's purely a matter of intensity. So frequency, dosage, duration. So tier 1, tier 2, tier 3. And also if a student is at a tier 3 level of need, we think the supports they're receiving are not replacing tier 1 and tier 2 supports. They need grade tier 1, they need grade tier 2, and they need grade tier 3. So I'll give you a chance to take a look at what kind of broadly defined a comprehensive school mental health system might look like. So this notion of what are the things that all kids get, right? So that's going to be prevention, that's going to be education, that's going to be screening, right? What are the things that some kids get? Maybe seeing a counselor once a week, maybe being in a group, right? What are the things that a few of the most struggling students get? In many schools, that's special education, and historically, that's been the only thing. There's a lot of challenges with putting all mental health in a special education box. Happy to talk more about that, but what we're trying to do is move away from a special education only way of thinking about mental health in schools. That's where Bright comes in. So the intervention that the team I'm blessed to be part of supports is what we consider a tier 3 intervention. So the kids at the highest level of need, often 3 to 5% of kids in school. And that's where the population that you all support is going to be, right? Is going to be at tier 3. I was talking with Dr. Stern, Jessie Stern, our chief medical officer at the Brookline Center last week, and she was saying she just intaked a new student with a diagnosis of early psychosis, and that student is back in school and they're in the Bright program and they're doing okay, right, Jessie? And so, and if the school didn't have that, then the experience of that student returning to school would be much different and much more difficult. So the intervention model is really simple, hard to pull off in practice, but really simple in concept. So there is a dedicated space. There is dedicated staffing, a clinical coordinator, and an academic coordinator. There's a careful selection of students, right? Making sure that we're not sort of flooding the space with kids who for whom it's not designed, which is a big challenge in schools, happens very often. And then each student is getting an individual plan that integrates academic, clinical, family, and care coordination supports. So you know, happy to talk more about it, but that's roughly it. We've been working, and I really want to express my gratitude to Dr. Gagan and the Empath team for really working to be out there and talking with folks in schools. Emily's presented at our conference. She's presented, you know, wherever she gets invited and wherever she can sort of get in there to talk with folks in schools. So thank you so much, Emily. And I think we have, you know, still quite a bit of work to do. One thing I want you to know is that if you have a high school student a public high school student in Massachusetts, they're highly likely to be in a school where they have Bright. So 2/3 of all public high school students in Massachusetts are in a school that has this intervention. So if you're working with a student and you're sending them back to school, or you're working with a student who's in school, it'd be a good question to ask, do you have Bright? And if so, are they in Bright? And then if they are, that's going to be a great connection, right? Because that team's job is to work with you to make school work for that student. You know, and then secondly, there's a whole set of organizations working on school mental health in Massachusetts. So I'm happy to talk more about that, but we really encourage making connections and partnerships. And then finally, it's been like delightful to be here today. And I have to say, I am honestly, and with humility, like a little bit surprised about the lack of conversation about schools as part of this equation. Schools are where kids are available to get support. It's where they live their lives. And it's where I think we all need to be together working to support kids. So just really want to invite us to continue this conversation of like, how can we be thinking schools, universities, employers into the amazing work that you all are doing. So that's it. This is our team. If you're interested, this is my very complicated email address, but if you just Google BRYT, it just comes right up and you can find me right there.
Thank you for bringing up schools. Paul, did you want to answer any questions? There's a question right there.
And I'm sure, yeah, I think a flaw we saw in students was that it really like separated them from the community, and for people who are going through any type of like foster system or just like family shake up, like it shows in families, like sometimes, you know, even our friends done after high school, like that's a team right there, like bring people to stay with or whatever. I'm wondering how it's changed now, it's like there's also an emphasis on like how you go about navigating like students who don't have that like care. And the same question is like to a person too, but like if someone that's not doesn't have like a solid like guardian or parent to write down like what do you do, and then also how you like different people to connected to their community of teachers or like graduates or whoever.
Yeah. Okay. So those are great questions. Let me say 3 things real quick, and then we'll see if I've gotten to what you're most interested in. One is, so Bright is designed as a short-term transitional intervention. So if a student's returning from an extended absence, they may spend a day or 2 in that room, sort of getting their bearings, figuring out what they're going to say when other kids ask them what's happening, you know, figuring out their path to return to a full schedule of classes. But then they're going to be back in school life as quickly as possible and as fully as possible without setting them up for failure or relapse. So the idea is, in fact, reconnecting them with their community of peers, making it possible for them to be in school, but also having a safe space in the school where they can be if they need to. So that's at least how it's designed. You know, the conversation among students at Brookline High, you know, may have been different and may know things about Bright that I don't, but that's at least our design. And then I cannot overemphasize the importance of the question of kids who are DCF involved, and how important that question is for us, and I think for all of us in this room. We are starting a pilot program with one large high school in Massachusetts to expand their Bright programs, but to focus specifically on kids who are DCF involved, and for whom, quite frankly, we're afraid that if we don't intervene more intensively, they're just in the school to prison pipeline. So it's really, really important. And so, thank you. Did I get at what you were asking? Okay.
Yeah, thank you.
Great. All right. Thanks, everyone.
Yeah, there's always more. That's a good way to end this session. So there are actually many more posters. These were only snippets from 6 of them, and some of them are still up. So after this session, I'm going to turn this over to Cashier, who's going to give the awards and maybe explain how we came to them. We had a long committee meeting and it was very difficult to figure out who would get the awards. I think all 45 of them deserve it, quite honestly. Yes.
Thank you very much, Lynn. And it was a wonderful session, as always. So it's my privilege to give out the 2 awards for the best posters. And it turns out that this time there were 2 that were tied for the first position. So let me read them out, and if they're still here, please come and receive them. The first one of them, first to the first place, is for Daniel Walker, and congratulations. The title of the poster was The Experiences of Black Emerging Adults with Psychotic Disorders Who Have Community Violence Exposure, a Phenomenological Approach. The second of the first prize is for Damla Duenda. Damla is not here. So the title is Leveraging Machine Learning Methods to Predict Active Suicidal Thinking in Young Adults with Schizophrenia. Dr. Brown is going to receive that. Congratulations. So, as Dr. Delisi said, every one of them deserved an award, but we had only a limited number as we have generally had. But congratulations to everyone, and every year it's getting better. So that's what I want to say. Also, it's my privilege to kind of summarize the meeting, or at least today's meeting, as we have done in the previous years. First of all, I want to say that it's been an incredible pleasure for me, and I'm sure for everyone else who has been involved with this, to see the growth of our community, so to speak, our community of early course psychosis clinicians and researchers and other individuals with lived experience all coming together to learn from each other and to grow our field. So this year we had the explicit title of Communities of Care as our theme for the meeting, and today's session was on translating from research to practice. So by research we mean translational research. And Dr. Geyer this morning gave some really nice opening remarks in which she reviewed the history of evolution of this program, beginning with MapNet a few years ago, and then LEAP and our partnership. And it's nice to have our guests from SAMHSA, Dr. Scott Gagnon and Dr. Laura Grubbs. Laura Grubbs gave a very nice overview of some resources for the early psychosis community. Then we had our keynote speaker, Jay Shaw, who in his talk, illustrated the importance of a learning health system model, which is what our overall mission has been as well over the years. The idea of a learning health system is that the system is like an engine that throws what we learn from the patients, data to knowledge. And then that knowledge leads to an innovation in services. And then we evaluate the impact of those services. And those evaluations will feed back into more questions and more data collection. And this is a cycle that goes on. And the real fuel that makes this engine run is data. And Jay Shaw illustrated how importantly collecting data in a real world kind of way on service users' experience and outcomes can be brought back to improve services. And he gave great examples of improving outcomes in the populations of French-speaking Canadians, French and English-speaking Canadians, as well as among the homeless populations by improving housing support systems and so on. He also pointed out, but I'll come back to that question towards the end, some of the steps needed for the future. We also had some wonderful oral presentations, and I won't be able to go through all of them, but Takaya McFarland gave a very nice review of the RAP program. Scanlon gave a very insightful observation from the RAISE ETP study that the longer people have stayed untreated, the longer DUP, so to speak, worse is the violence characteristic. So this gives us a potential preventive opportunity by early detection and reducing the duration of treatment delay. One might be reducing, not only improving outcomes, but also reducing consequences such as criminal legal involvement. Joey Rodriguez presented data from the CEDAR showing the importance of support for Latin populations in terms of mental health services, customized to that population in need. Alma Bartnik, from the ServiceNet Prep West program, showed the value of participatory research, especially the importance of peer connection in driving outcomes, better outcomes. Megan Good from our own Aspire program showed some really insightful data on how continuing cannabis use versus non-cannabis use makes a difference in terms of persistent or worsening quality of life and other outcomes. It again highlights the importance of learning care systems, such as what we do to focus on the important risk factor of cannabis, which is expanding in the United States with worsening cannabis exposure in young populations who are at vulnerable risk for psychosis. And finally, Paul Hyry-Dermith from the Brookline Mental Health Center described the BRIGHT program and the important value of support in an individualized way for school-going kids with mental health difficulties. So let me add my own thoughts on where the field is going. Really, this is all heartening in terms of communities developing and a learning healthcare system emerging across the nation and in Massachusetts, which is really beginning to yield results. And we are growing, as we see over the years, and more to come on that. But also in a broad way for the field of early intervention in psychosis, as is the case in the rest of psychiatry, we are at a point Jay Shaw made this point at the very, very beginning. He showed a slide where there is this trajectory of psychosis, which is going down in a number of people. And then the early intervention programs might bend the curve, so to speak, to reverse course. To some extent, in that paper, Jay highlighted, the key distinction was made between, applying what we know and making the unknown knowable. So I think a lot of what we are talking about today in these meetings is about applying what we already know in terms of interventions for psychotic disorders. But there are a lot of unknowns. Why is it that a number of people don't do well down the road? The OPUS study, for example, shown the sobering findings that at 5 and 10 and 20-year follow-up, people with early course psychosis who received early interventions in psychosis don't look much better. Why is that? There are these diseases processes that are continuing, for which, we don't, at this time, our treatments are palliative. We do not yet have disease-modifying interventions. That is where a lot of work needs to go on as well. And that has to go hand in hand with applying what we already know as well. So the key goals for the future would be not only to improve outcomes in our patients early on, but also sustain those benefits down the road. Some of this will come up tomorrow when we'll be discussing about the AMP program, about efforts, which is a multi-stakeholder driven effort by the FNIH to understand the roots of psychotic illness. And there's a long way to go, but I think the direction, the things are moving in the right direction. So with that, I want to thank everyone. And, we have a very exciting day tomorrow.